All right, so as Julie noted, I work at the Adult Down Syndrome Center in Park Ridge, Illinois. It opened in 1992, and we've seen over 6,000 patients with Down syndrome since its inception. And our mission is to enhance the well-being of people with Down syndrome who are ages 12 and older by using our team approach. We have 4 physicians, an occupational therapist, myself, patient advocates, and a whole nursing team, and we all work together to serve our patient population. Please just note that this presentation is for families, caregivers, healthcare providers, or other service providers for people with Down syndrome. It's for educational purposes only, and so we recommend that if you have any really specific questions, that you bring those to your medical and/or therapy providers. Also, as an additional sort of note, the purpose of this presentation is to inform. I always want to make this note known that mental illness, mental health concerns, they happen, right? Each person is an entirely unique combination of genetics and environmental influences. So I don't want anyone's takeaway from this presentation to be that if their loved one with Down syndrome has a diagnosis of a mental illness or has other mental health concerns, that, oh, I could have prevented this, or this is my fault, I've done something wrong as a family member. That's certainly not what I want you to take away. That this is just to help prepare if you haven't reached certain phases of life yet, things you can do to plan, or in some cases prevent or minimize the impact of mental health concerns and or cope with various situations, right? Mental illness, as we know, hopefully we all know in the year 2024, it's not a character flaw or there's nothing, a moral failing. These are just things that can happen, and we want to work through and sort of just inform about different ways to address these needs. So what I'll be talking about today is I'm just going to review the common characteristics of Down syndrome, discuss concerns and topics at the different ages and stages of life, discuss some general strategies to promote mental health, and discuss additional treatment approaches before having some time for questions at the end. So I just would like to always go over the common characteristics of people with Down syndrome. We always say here that if you've met one person with Down syndrome, you've met one person with Down syndrome, because we know that each individual is entirely unique and special in their own way. But we do see that there are some common characteristics that across the population at large, we see over and over at our clinic. So the first is what we call the groove, and that's the tendency towards sameness and routines. We know many people with Down syndrome really thrive on their routines and doing things a certain set way. And so that's what we call the groove. We also know that many people with Down syndrome engage in self-talk, which we see as a way of processing, coping, analyzing. So self-talk is another common characteristic. Many people with Down syndrome are also concrete thinkers. They think in black and white. And so some of that abstract thinking or thinking about those gray areas or taking a different perspective can be challenging. Many people with Down syndrome have very strong visual memories. So the things that they have seen or experienced can replay in their mind as if they are happening in that moment. And many people with Down syndrome have very strong empathy radar, where they can pick up on the emotions of others and sometimes even internalize the feelings of others as well. So how this relates to what I'm talking about today is that we say these common characteristics are not a problem until they are a problem. So we always encourage families and caregivers to think to themselves, are the behaviors that I'm seeing in my loved one problematic, or just kind of annoying or different than the way I would do things in my life? Do these behaviors impact the individual's ability to function in their daily life? So for example, the groove versus OCD, sometimes it can be hard to distinguish, but is it functional? Does it help them get through their day? Or is it preventing them from getting through their day? We also see sometimes some misdiagnosis or confusion between self-talk and having hallucinations, or same with the visual memory. Is the person having delusions or hallucinations when they're engaging in these in visual memories. An empathy radar. If the individual is spending a lot of time with a certain individual who maybe has certain behaviors or demonstrates certain difficulties managing their mood, are they just sort of empathizing with that individual? And if they were separated from that person, would those issues resolve? And so we think about these common characteristics that they can be really positive and protective. So like having a set routine and engaging in self-talk can be very regulating and help the individual process and cope through their day. And so we see some families say things like, well, I don't like the self-talk, I don't like the way it looks or the way it's perceived. And so we want to eliminate that. But by trying to sort of reduce that coping strategy, how might that dysregulate the individual in other ways? And so thinking about maybe this is not such a problematic set of behaviors if it's really helping them cope and process. We really like to get family members and caregivers on board with these common characteristics because we know that a lot of our patients with Down syndrome have somebody with them at doctor's appointments. And so family members and caregivers' awareness of these common characteristics can really help prevent misdiagnosis or misunderstandings. We've had a lot of people come into our clinic who were seen by other providers, and they already have in their medical chart a diagnosis of schizophrenia or OCD or psychosis. And then when we meet with the patient, we really kind of have a different perspective because we know these common characteristics. So, you know, a family member, the way that you present information to medical providers or to therapists can sort of help direct them either towards a misdiagnosis or and one more accurate diagnosis. We have a lot of family members who say like, oh, my son is so OCD about his clothes and picking out his clothes at night. But again, if it's functional, if he's picking out his clothes the night before so that he can be prepared for the next day, then that's a functional groove, even if it's, you know, he has to do it at a specific time or a specific way. Whereas if a family member, you know, is saying to a medical provider, he's so OCD, a doctor might just write that down and put that in the chart and maybe even prescribe medication when we don't always find that to be necessary. So just things to consider when you are interacting with providers. So starting with childhood as the first sort of stage of development, I'm going to go through some issues of concern that we see and then some strategies that we can use in childhood. So some issues of concern that we see is that for many children, there's a lack of awareness of their emotional state or maybe a suppressing of emotions. And many of these issues are common for all children, right? Because this is how children learn and they don't have much familiarity with these things. But we do see that maybe it takes a little bit more effort or explicit teaching for people with Down syndrome to sort of keep on track with these stages of development. So some strategies for mental health promotion are co-regulation, especially for young children, right? And that's the process through which kids develop the ability to soothe and manage their distressing emotions. We can't regulate ourselves until we have learned to regulate with the support of somebody else, a parent, a caregiver, teachers, staff, that can help sort of work through the emotional process. And so it's really important that everybody's sort of on board with that. I've seen, you know, in education plans for even really young kids, goals that are like, oh, they will be able to self-regulate, when really that's not a possibility at their stage of development. They need to be able to co-regulate with someone before they can learn those skills to do that independently. Emotion identification is a real challenge that we have, even with the adults that we see at our clinic, because for a couple of reasons. We believe that the idea of interoception, where individuals with Down syndrome can sort of identify their internal state. Oh, my heart's going really fast, or my cheeks are feeling red. What does that mean for my emotional state? We know that can be challenging for them. We also know that many people with Down syndrome tend to be people pleasers, and they have learned from a young age that when I say I'm happy, other people are happy. So we see that individuals with Down syndrome may be clearly upset, crying, or really angry, enraged. But if you ask them how they're feeling, they'll say, I'm good, I'm happy. And so they've learned that that's just what I'm supposed to say. But we want to get them to be able to identify accurately how are we feeling so that then we can learn how to manage those feelings. So that goes along with teaching that all emotions are okay, although all behaviors are not. And that's another area where many people associate the feelings and the behaviors as one and the same, right? I'm not angry because that means I'd be punching and hitting. Well, no, you can be angry without punching and hitting. So separating those things. We want safe, healthy, positive expressions of emotions. And so those can be explicitly taught. We as caregivers want to model safe and positive coping skills, using them ourselves. And parents and caregivers, of course, can remind the child that they are loved and valued no matter what their feelings are, so that they don't sort of internalize, people only want me to be happy, people need me to be happy. So moving into coping skills, some issues of concern that we see in childhood are that there is just a general lack of coping skills. Again, this is all children. All children need to learn coping skills. But this is something that we see that maybe individuals with Down syndrome don't get as much instruction on, and then it takes them longer, or it's more difficult for them to pick up on those things. And people with Down syndrome may have more difficulty communicating their needs, which then makes learning coping skills challenging. So some strategies for mental health promotion would be just really beginning to learn how to handle various emotions. And that comes through the modeling of good coping skills, right? We've got the co-regulation, and then we're modeling, and we can speak it out loud, and that makes it more explicit for the individual. So talking, I'm feeling frustrated that dinner got burnt. So I'm going to take a few minutes to take some deep breaths and come up with a plan of how I'm going to fix it. It's important for kids, and especially people with Down syndrome, to see that we all have a full emotional experience, right? We know that because people with Down syndrome have empathy radar, many times caregivers or family members will try to like, everything's good, don't worry about me, I'm fine, right? But then the individual doesn't really get to see, oh, mom and dad get angry too, and this is what they do with their anger. So we want to be able to model those coping skills and talk them through, yep, it's okay when I get angry, this is how I'm going to handle it. You can also provide multiple ways to communicate wants and needs. If verbal communication is challenging, we can use visuals or gestures or communication devices. That helps communicate so that then they can cope. Distraction and avoidance can be used when necessary, but we really want to focus on teaching the coping skills. So like for kids, sometimes we try to distract them. So if they're upset that they can't play with the toy they want to play with, we say, oh, don't cry, don't cry. We've got all these toys over here. Play with this instead, right? We try to distract them from the emotions that they're feeling to get them to be happy again, which I understand as a parent, there is a time and a place when that is necessary, but we don't want to do that all the time. We don't want to just try to eliminate being upset. We want to build those distress tolerance skills. I see that you're upset that the toy you wanted to play with is not available right now. What can we do? How are we going to take some deep breaths? How are we going to fix this problem? Wait your turn or find something else to play with, and help them work through that on their own. Also, we see a lot of families engaging in some of that avoidance where, oh, well, he always throws a fit when we go to the park with the swings because he has to wait his turn. So let's just not go to the park with the swings. Again, that's not really teaching the individual how to cope with challenging feelings. And so there are times when we actually want to challenge them and allow them to have that experience so that then we can teach them in a safe way how to work through those feelings. We also want to validate feelings without being too quick to turn it around. I've seen this a lot in my patients as adults, and so I assume, it's also been happening through childhood, where the person with Down syndrome is upset about something legitimately upsetting, and a parent or a sibling or a caregiver goes, yeah, but we're good. It's all good. We're cool, right? High five. Come on, we're fine. And that's really confusing, right? It's invalidating that about their emotional experience, but it's also confusing because we want the individual to learn this is what my body feels like when I'm sad, or this is what my body feels like when I'm angry. But mom says I'm all good. So this is good, right? And so it's confusing. We want to be able to say, yeah, you seem upset. That's upsetting, and validate those feelings. And then we can teach different calming and coping skills. We have found that when we teach calming and coping skills, it's been helpful to sort of separate the two out, because what we've been finding with our patient population is that they're really good at identifying calming strategies. I'm going to take my deep breaths. I'm going to get a drink of water. I'm going to count to 10. And those are all really great and useful. What we find to be the challenge is that people with Down syndrome, they've got that really good memory. So even after they've taken their deep breaths or counted to 10, they're still thinking about it. They're still perseverating on it and thinking, and they haven't actually found a way to cope with those feelings. So we say, yeah, you're going to want to calm yourself down so that you don't explode in the moment. But then we also want to take the next step of, how am I going to solve this problem? Do I need to come together with somebody else to compromise? Do I need to talk about my feelings? Do I need to solve a problem? What can I do to actually more deeply cope with the thing that's upsetting me? And we have lots of resources on our resource library about different visuals and ways to make a plan about how to cope with feelings. And so I'll share the link with my presentation where you can access all of these resources for free. Another area of childhood, working on social skills and boundaries. So some issues that we see is a lack of awareness of appropriate social skills and boundaries. Again, all kids tend to express themselves physically, whether they're happy and they're hugging or they're angry and they're hitting. But again, really important to learn appropriate social skills and boundaries. Because there's this issue of vulnerability, that many people with Down syndrome may need the support from caregivers, or they may have limited communication to express when something isn't right. And so we want to be able to help them understand appropriate boundaries and social interactions. We also hear that there's maybe not always exposure to opportunities for practice, depending on the school setting or the environment that they're in. They might not have the opportunity to practice, for example, if this child is verbal, but it just so happens they're in a special education classroom entirely with students who are nonverbal, or so we want to, or at different levels of social skills, we want to make sure that they get the opportunity to practice and grow their skills. So some strategies for mental health promotion is that these skills may need to be explicitly taught, right? Whereas some children without Down syndrome can naturally sort of pick up on the social cues of others or recognize the consequences of social behaviors, right? Like, oh, if I'm picking my nose in class, the other kids will say, ew, gross. And then I will never do that again. Whereas maybe someone with Down syndrome wouldn't necessarily notice that about themselves or make that connection, or even be in a class where other people would sort of point out that behavior. So it might need to be explicitly taught, about boundaries or social skills and how to interact. The idea of bodily autonomy and consent. This one is a little bit of a soapbox issue for me. We know that in our experience that many people with Down syndrome can be very touchy-feely. They love to express their love or their, appreciation physically. They like to hug and touch your hair and everything. And so, but we really want to teach the appropriate social skills, that if anybody else without Down syndrome touched you that way, came up to you and hugged you or touched your hair, you'd be like, wait a second, that's kind of strange. And so we really want to work on the concepts of appropriate touch for when they're touching other people, but also for people touching them. We've unfortunately, working in the adult clinic, we have heard stories about, sexual misconduct, either by a caregiver or a staff member, or even between people with Down syndrome, because they didn't understand what was appropriate, what was acceptable, and what was not. So we really want to teach them about having control of their body, getting consent before other people touch them or before they touch other people, because it's really important as they get older. And so we can practice that even in childhood when you're giving the kid the bath, telling them, okay, mommy's going to wash your private parts now, or I'm going to, is it okay if I touch you here? And sort of talking them through so that they learn to recognize that it's their body that they have control over, and other people should not be touching it in ways that they don't want them to. And that goes both ways. We shouldn't be touching other people in ways that they don't want to. And we have to respect it when people say, no, I don't want a hug. Okay. And then we want to make sure that the individual is getting opportunities to practice social skills with individuals of various abilities. So if they're in a special education class where maybe they don't get as many opportunities to talk, making sure that they're getting opportunities to practice and grow their skills, so that they can keep developing and keep being challenged. And again, we have lots of visuals on our resource library, things about personal space and friendships and rules for conversation. So these visuals are intended to help make it more concrete, because we know we want to play to the strengths of the people with Down syndrome, and knowing that when they see something, they tend to retain it better than when they hear it. So we have a lot of visuals with things written down and pictures so that you can review these strategies with them. All right, so in childhood, we also want to talk about having Down syndrome, having that diagnosis. Some issues of concern that we see is that this plays into the individual's self-esteem, or maybe confusion about what that means. We know that Down syndrome, right, there's a whole spectrum of abilities, whether it's cognitive abilities, communication abilities, physical abilities. And so we've heard from some, patients who are more communicative or have really high cognitive abilities, that they feel left out, right? I don't fit in with many people who have Down syndrome because I'm able to express myself better than they are. But I also don't fit in with people without Down syndrome because they don't see me as their peer. And so that can be an issue of concern that we hear about. So some strategies for mental health promotion are supporting a positive self-identity, right? Making them aware of their diagnosis. We've had adults, middle-aged adults, they pull into our clinic for the first time, they see the sign and they say, why am I here at a Down syndrome clinic? Because they've never been talked to about having Down syndrome. And not discussing it, we found, can make it really seem taboo or like it's a negative thing, which certainly we don't view it that way. We always want to identify and highlight strengths, right? What are things that you're good at? What are things that are special about you? What things that you enjoy about yourself? Another strategy is to learn together as a family about Down syndrome, right? Nobody wants to feel like their parents know everything about them, right? Because they're an individual, and maybe it's beneficial for them to be able to tell you about themselves, but also learning like, oh, other people with Down syndrome have this too, or they do that as well. Oh, I thought I was the only one who did that. And so learning together can sort of spark conversations and interest, and letting your loved one with Down syndrome know that, yeah, this is an important part of you, and we all want to support it and learn more about it. You can discuss ways in which all people have differences or things that make them special, unique, just sort of validating that, yes, we're all different. There are things that I struggle with or things that make me special, just as it does for you. We also want to answer questions honestly and kindly. We don't want to negate or deny that some things may be harder for a person who has Down syndrome. I hear from a lot of patients, my parents just don't get it. They say, having Down syndrome is my superpower, but it doesn't feel like that when I'm struggling with X, Y, and Z. And so we know that family members and caregivers are super well-intentioned and well-meaning, and we may view Down syndrome as a superpower, but if that's not how they feel, they might have questions about why are certain things harder for me, or why do I have Down syndrome? And to answer questions honestly and say, you know what, this is just a genetic condition. It doesn't have to be doom and gloom, right? We don't want to bum people out, but we also want to answer things honestly and give them concrete information that will help sort of knowledge is power, right? It might sort of settle some of those feelings that go along with it. We think it's really important to connect with others who have Down syndrome or other intellectual disabilities. Again, this goes back to feeling left out or in the middle. Some people, we have heard that they, perform really well in school, and so they're able to be in sort of the mainstream or general education classes. So that becomes their peer group. But then when all those other students graduate or go to college or get jobs, and that peer group sort of disperses, the person with Down syndrome can be left feeling like, well, where do I fit right now, right? Maybe I didn't go to college like my classmates, or I'm not getting a job, I'm not on the same timeline as them. And so that can make it harder. And then always finding activities that they enjoy and getting them involved and keeping them involved, right? If you are really good at a sport, that can boost your self-esteem, or if you're really good at art, that's another way to improve self-esteem. Parenting and siblings, these are issues that we hear about a bit. Some issues of concern from families is, how do I make things fair? How do I parent my child with Down syndrome versus my children who don't have Down syndrome? Do I keep it the same across the board, or do I make exceptions or special permissions for my child with Down syndrome? And then the division of time between siblings. We know that sometimes people with Down syndrome require more doctor's appointments, therapies, time just to talk through things. And so that can sort of lead to some challenges when you've got other siblings in the mix. So some strategies for mental health promotion is about finding the balance. We hear from families the full spectrum of experiences. Some families say, well, I don't treat my child with Down syndrome any different than the rest of my kids. And some people say like, oh yeah, my child with Down syndrome gets lots of extra attention, or they don't really have chores that they have to do like the other kids do. And so the most positive outcomes that we hear about from families are where it's somewhere in between, right? We want to consider fairness and abilities when parenting children of different abilities, because we do want people, our loved ones with Down syndrome, to learn responsibilities, learn consequences, and that really starts at home. We also want to consider differences in personalities amongst the children, right? This is true for Down syndrome or not, right? That some people want to be celebrated or even receive consequences in different ways. So we might have to make adjustments based on the individual. And we want to encourage positive sibling interaction. So if there are ways that we can get the siblings together, get them on it as working as a team, then that's always a good thing, because we really know that those sibling relationships are important as they get older, and it's always good to have good positive relationships, so that we don't want to start building in habits that can lead to resentment or discouragement between siblings. And remembering that fair does not always mean equal, exactly equal, that fair is like everybody gets what they need, which may look different. So maybe you need attention in the form of hugs and snuggles, you need attention in the forms of conversations, or whatever it might look like. We want to make sure that everybody's getting what they need to be successful and to thrive, although it might not look exactly the same across the siblings. So moving into adolescence. So this is a topic, the puberty and sexuality, that can, should, and has been its own presentation because it's such a big topic. So I'm just going to basically touch the surface of it. Some issues of concern we see are puberty and changes, the physical, mental, emotional, and behavioral changes, comfort of caregivers in discussing tough topics or things that they may be uncomfortable with, the safe and healthy expression of sexuality and sexual urges in the individual with Down syndrome. So some strategies for mental health promotion are talking about things before they happen, what to expect. This is true for all people. It's much better to know what's coming than to be caught off guard. So talking about it early. And also, it's not a one-time conversation, right? This is true, again, for everybody, that the information you got at school as a 4th or 5th grader you needed more information as you got in a little bit older, right? And so it's not a one-time conversation, but especially we know that people with Down syndrome benefit from repetition, from hearing things multiple times, maybe different ways, using visual supports. We have at our clinic some admittedly a little bit creepy, but they are anatomically correct dolls that we can use with patients to help them learn their anatomy and what happens during puberty or it looks like when there are sexual urges, things like that. So it helps to sort of reinforce a lot of the ideas. We want to normalize the changes, of course, that everybody's going through these at one time or another. You're not strange or gross or weird when your body goes through these changes. It is normal. But again, they might not have the exposure to the peer group that we had growing up, where, oh, yeah, you could talk with your friends about when you were going through some changes. So they might feel really isolated when things happen. I don't have anyone to talk about, or I didn't know that my friends were also going through this. So letting them know that it happens to everybody. We want to support healthy habits by teaching skills. This is, again, back to that explicit teaching. Things like changing a pad. You might have to, for girls, you might have to set up a schedule or reminders on their phone to change it. Our occupational therapist even has a visual aid where she has a pad that she's used a marker to color in and saying sort of like, when your pad looks like this, it's time to change it, because they may need that visual representation. They might not know what do you mean change my pad? When? How? And so really teaching all of those skills. And same for boys. We hear a lot of times the schools call us being like, well, what do we keep doing because they keep getting aroused, they have erections, and that's a problem. Okay, well, how are we teaching them? What can you do if you're at school and you notice that you have an erection? How can you cover yourself up? How can you excuse yourself? How can you sort of think about other things so as to sort of shorten the amount of time that we have this experience, right? We also want to get really comfortable having uncomfortable conversations. Um, Again, we we who do not have Down syndrome or intellectual disabilities get a lot of information from various sources, right? At school, you can learn things in books, you can learn things from your friends, you sort of just hear or learn things when you're watching TV or movies. But for individuals with Down syndrome, they may not have all of those sources of information. So much of it comes from the families. And so depending on your comfort level, you just sort of have to get comfortable talking about different things and answering questions in an honest way, using correct terminology and really sort of checking for understanding, because they just don't have the exposure to learn it from other places. We also want to promote health, safety, boundaries, and consent. This is, again, going back into that topic from childhood, that if we're teaching it all along, okay, just because you have a crush on somebody doesn't mean you're in a relationship with them. Just because you're maybe in a relationship with someone doesn't mean that you get to touch on them and kiss them all day long. And right, we want to teach the boundaries of what's acceptable behavior, where you can engage in certain behaviors, and privacy, all that good stuff. And we also, last point, is monitoring internet use. This again goes along with what I said before about context, right? We've heard from some of the patients we see that they've gone online and either stumbled upon some, pornographic material or really niche things, and without the context of knowing or the experience of being like, wait, this is not really what the real world is like, or this is not a common thing that happens, there can be some confusion about like, oh, this is what sex is, or this is what I'm supposed to do as a man or a woman. And we want to make sure that we're checking in that what you see on the internet is not all real, and that's not a common thing that happens in real life. So don't expect that to be your experience. So just checking and making, maybe setting boundaries on the amount of time on the internet or what sites they can access can be really helpful in sort of reducing some concerns that can come along with that. Teenage rebellion. So some issues of concern that we hear from families is that they want to allow for the individual's desired independence, but they also know that there may be difficulties ensuring safety or allowing, working within the individual's ability level. That there's some frustration of caregivers or school staff with new behaviors or moods. And then behaviors towards parents. We hear a lot of times that like a parent will come in with like a 19-year-old and say like, in the 19 years of his life, he has never been this way. And now all of a sudden he's rude, he's slamming doors. And, they're concerned that it's a mental health issue or there's something going on. And we say, well, what were your other kids like during their teenage phase? And oh, right. That it could just be normal teenage behavior because teenagers are teenagers. It's a normal stage of development. Remember yourself or your other kids when you were going through your teenage years. Nobody is in a good mood all the time. And this sometimes really seems to hit people, the Down syndrome population, because there is that stereotype of they're always happy, they're in a good mood, and or they've never had this problem before. But we know that that's not the case, that they have the full range of emotions. Hormones are at play. That normal desire for increased independence is going on. And so it can lead to mood swings. Obviously, you can talk to a doctor or a medical provider if the behaviors seem extreme or concerning safety-wise, but also we want to consider that this can be just a normal part of teenage development. We know that the timeline might be different for people with Down syndrome. So, it might be starting at 19 or 20, when with your other kids, you would have seen it more at like 13 or 14 or 15. And so it might be longer. It's kind of like a little bit of a moving target. It's a different. We want to provide safe opportunities for independence because we know that that's a major desire for teenagers, that they want that independence and to show that they know what's up. So finding opportunities that they can do that, whether it's like dropping them off at a safe place like a Starbucks or at the movie theater for a designated amount of time, picking them up. Now that we all have cell phones, that's a great way that you can sort of track the location and sort of monitor that they're where they're supposed to be, but allowing them that freedom because we know teenagers do not want to be around their parents many times. Picking your battles. If there are things that you can let go, I can let it go, right? Giving them some sense of control over things that are not as important, like the clothes they wear. Allow for safe, natural consequences. Obviously, we don't want to put our loved ones in harm's way, but if there is an opportunity to let them learn, like, oh, well, you didn't call me when you were supposed to, or you didn't text me that the movie was over, so now you have to wait until I can come pick you up, right? Like giving them those opportunities to learn from their mistakes, because that's how, for all of us, how our brains grow. That's how we learn, is that we do make mistakes. We have some natural consequences. And then next time I'm going to remember that a lot better than if I just get a lecture from my parents of you were supposed to text or you're supposed to call. That won't stick as well. Allowing for that power and control when possible, and having firm boundaries that can remain in place for things that are non-negotiable in your family. I'm not saying, like, all right, just let them do whatever they want. If there are things that you feel strongly about, then those firm boundaries can remain in place. You may want to assess, though, that if you're noticing you have a lot of non-negotiables, you might need to reassess sort of which are the most important or which you want to focus on at a given time. Some households have a lot of rules, but if you're in a situation where your loved one is giving you a lot of pushback, we can see how this escalates and can put tension and negatively impact relationships within the household. And sometimes the individual with Down syndrome, rather than learning the lesson behind it, is just really focused on the person who's enforcing the boundaries or giving the consequences. And then they're just, I'm so mad, dad is such a jerk, rather than actually learning, why is dad putting certain boundaries in place? Why are there certain rules that are enforced? We hear a lot about the idea of fantasy world for people in this age group, and that the issues being that there's a lack of awareness of what is reality and what is fantasy, or there's too much time spent zoning out or fantasizing or engaging in self-talk, or when they do talk with other people, they're only talking about their fantasies. and maybe even refusal to engage in real life activities because fantasy world is just much more interesting and engaging. So some strategies for mental health promotion. This is another example of it's not a problem until it's a problem. All of us slip into like little daydreams or fantasies from time to time, so it's normal. But people with Down syndrome have those very strong visual memories, so it can become very real to them. And we hear that the reason that maybe they engage in this fantasy world is that it provides an escape from the real world when the real world is stressful. It's also an opportunity to process, sort of like playing through, like when all of us like on our drive home or in the shower where you're like having that argument that you ultimately win. It's their way of processing through things. It gives them different types of social interactions that they might not have in their real life. Maybe they have a boyfriend or a girlfriend in their fantasy. Maybe they're super popular in their fantasy world, which is maybe different than their real life experience. They maybe have more control, or they're accepted in different ways. These are all sort of things that have been shared with me from my patients about why they're engaging in fantasy world. So we, as families, we want to try and keep clear boundaries between fantasy and reality. I know that sometimes it's natural. It happens where as family members, we say, oh yeah, that's your boyfriend, Zac Efron, right? You guys are going to get married. Just sort of like lighthearted joking and teasing, but that can actually make it really much more confusing for the individual with Down syndrome to distinguish reality from fantasy. I've had patients who like really played into the fantasy. And so like I have, middle-aged adults who are really convinced that they have superpowers and that they can put curses on people. And it's confusing when people try to say, well, that's not really the case. So we want to keep the individual busy with activities. We find that sometimes after high school or when there's too much downtime, whether it's over breaks or on vacations, that the more time they have alone to think in the fantasy world, the deeper they can get into it. So we want to keep them engaged in activities that require like cognitive engagement. So like a lot of our patients really love coloring or doing activities of that nature, which is great. But while you're coloring, you can still be thinking about fantasy land. So it's better to have activities that require them to engage with their surroundings, sort of be in the present moment, so that they don't slip too deep into that. Monitoring screen time. We want to be aware of what they're watching, how much, how often. We see people really slipping into a routine of watching the same things over and over, which then can intensify the fantasy because they're really living in it. So we also want to be aware of the themes or the content of what they're watching, because I know there are a lot of popular shows on like Disney that play into like, I'm a superhero or I have superpowers, and a lot of patients watch that show and then they are convinced that they too have these these superpowers or special gifts. And we want to consider what the fantasy is providing for them. Is it a way that they calm themselves down? Does it give them control or power? Is it the desired relationships they're seeking, independence or freedom? And then is there a way we can provide that for them in their real life? Give them more opportunities to get what their fantasy world is giving them in real world. Inclusion. So some issues that we see are that they feel left out from their same age peers, like I spoke about before. There may be difficulty coping with changing relationships. This is something we see a lot, that after high school or after the transition program ends, they're incessantly texting their former friends or staff members like hundreds of times a day. And it's hard for them to sort of move on when relationships change. And self-esteem. So some strategies that we suggest are, again, having friendships or connections with other people who have Down syndrome, maybe, ideally if they're local or people that they can still spend time with, share their experiences together and stay connected when others, if they're general education or mainstream peers have gone off to college, well, who can I still hang out with or who can I still connect with? Preparing and setting expectations for how friendships may change over time. This is something that is hard for a lot of us, but it is a natural part of life, that the people you were friends with when you were in elementary school may be different than your friends in middle school, high school, college, and beyond, and that's just a natural part of life. But we find that our patients have a really hard time accepting that or understanding that, and maybe taking it really personally when people don't respond to their texts. And that can really lead to some sort of sad feelings or some compulsive behaviors, like with texting and calling people. So we want to make sure they have regular opportunities to meet, connect, and engage with people, because if your best friend has sort of moved on in life, well, where does that leave you? We want to make sure that there's the opportunity to see new people and to form new relationships. Thinking ahead to the future, issues of concern being like that there are a lack of activities after high school or transition. There's sometimes uncertainty about programming or employment, and wanting to do all the things that their friends or siblings do and on the same timeline. They're upset that my brother got married when he was 25 and now I'm 25. They sort of imagine that that is the correct schedule and that they want to be on the same schedule. So some strategies for mental health promotion are thinking about programming after high school or transition, sort of planning ahead, working with school staff, transition staff, really getting prepared for when that time comes. We don't want them to sort of, as we say, sort of like fall off the cliff where I was in school for 7 hours a day, 5 days a week, and now I've got nothing. So thinking about which programs, jobs, activities, college classes to keep them involved. And if there's nothing available, or if you're on wait lists, this is something that we recommended during the pandemic when nothing was open and nothing was going on. Still, like, trying to make structure in their day, giving routines like with chores, times to get out of the house, exercise, special rec programs, visits to different family members, keeping them busy so that there's not just a lot of sitting in isolation. Promoting different lifestyles or goals. Not everybody gets married. Not everybody goes to college. Not everybody buys their own house or lives on their own. And so giving them exposure to the fact that, you can be successful, and that might look different than what your brother thinks is his version of success. And that's okay, right? Because if they only see that success means going to college, getting a job, getting married, if those things don't fall in place for them, there's gonna be some self-esteem issues and some sort of some real disappointment. So allowing them to know that, yeah, that's not for everybody, and that's okay. And then working on skills that reach future goals, that help reach future goals. We have a lot of people say, my goal is I'm going to get married. Okay, great. But husbands and wives don't just fall out of the sky. So if you're interested in getting married, what are steps that you can take today? Well, you have to meet someone and you have to talk to someone. So where are places that we can go? Should we sign up for special rec? And so that you can go and talk with more people, right? Setting these like tangible goals that they can achieve today to help them reach their long-term goals. Moving on to young adulthood, this kind of goes along with what I was saying, the post-high school and transition slump, where there's a drastic change to the schedule. There's fewer opportunities for movement and socialization. I can't sort of say enough about the movement aspect. You get so much movement just naturally in a school day, getting up and out of your chair, moving around the building, on and off the bus. And that proprioceptive input is really helpful in regulating. So when we're not getting up and out of our seats, when we're not moving around the school building, we see a lot of sort of dysregulation in our patients in the young adulthood. Many of them feel overwhelmed about the future. The concept of future is confusing, right? Every day, every tomorrow is the future, but it's hard for our patients to understand that. Their identity as an adult, especially if they're living at home or they're still, having caregivers help them, take care of them. Well, I thought I'm an adult right now. Lack of awareness of options for what you can do after high school, being on wait lists here, at least in America, wait lists for day programs and residential placements are very, very long. And so families kind of get stuck being like, well, what do I do if it's, not going to be another 10 years before they can even get in this program? Or depending on where you live, a lack of options for programming. There just might not be a lot where you live. And the cost of programs. Some of them require pay out of pocket, and that can be very, very burdensome to families. So some strategies for mental health promotion are finding ways to stay busy within your ability level. Again, making a daily schedule, ways to get people involved and stay active and getting that movement and that socialization. You all can work with school staff or with government agencies whose jobs it is to help connect people with supports and options. Look for continued opportunities for movement and socialization, finding opportunities for continued learning, right? We don't want to remain stagnant. All of us, we want to be lifelong learners, keep those cognitive muscles flexing and growing. Discuss the meaning of being an adult and what it looks like to the individual with Down syndrome. This is something that we hear a lot of discrepancy about, right? That some people with Down syndrome, the moment I'm 18, I'm an adult, or the minute I graduate, I'm an adult, or I will be an adult when I get married. And so it looks different, and we want to make sure that people are the families are getting on the same page with, well, you're an adult when you're 18. That's technically true in the legal sense, but what does that mean in terms of responsibilities for being an adult and obligations? And are you still an adult if you're still living at home? Yes. How can we make that you feel secure in your adulthood while still working as part of the family unit living at home? And sort of mapping that out as a family and talking about those things. We want to maintain habits and skills. So a major concern that we see is that there's a lack of opportunity to practice skills or the lack of need to demonstrate habits and skills. And so we see some of that motivation plummet after high school or after transition with our patients. Things like, well, I don't have to get up today. There's nothing interesting going on, so I'm going to lay in bed in my pajamas all day. And then you have enough days of laying in your pajamas all day, and suddenly they're not showering anymore. There's no need to shower. I'm not going out. I'm not going to see anyone. And so then we start maybe regressing in some of those skills that we previously had. So some strategies would be to continue to hold the individual to prior standards. No, we're still going to wake up every day. We're still going to get dressed. We're still going to do chores. Keeping those routines in place, because we know that if a habit falls off, it's really hard to rebuild it back up. Create motivation or reasons for the individual to continue demonstrating their skills. This is something that's really hard for a lot of our patients that I work with, finding that motivation, because it can be true for many people that if I didn't have a job because I need to pay bills, and why would I get out of bed? Why would I brush my teeth in the morning, right? It's much easier to just lay in bed watching TV. So then we have to find reasons to motivate them. Okay, well, we're not getting electronics until we've done X, Y, and Z. And I know that's really hard for families because yes, they're an adult and I shouldn't have to treat them as a child. But again, we have that motivation, right? Like, I'm not going to get paid unless I go to work. So if I don't have that internal motivation of I love my job and I want to go, then that external motivation of, well, I do need to pay my bills. So that's the reason I'm getting out of bed. So that might help as a perspective shift, and when it's hard for parents to sort of implement these things with their adult children. And we want to encourage the development of new positive skills. So, right, we can always learn things. We can always try new things. It doesn't just have to be that, oh, I did that in school, or I'm done with that. I did that when I was in middle school. No, we can try new things and we can develop new habits. There's also this comparison to peers and siblings. So we want to maybe be on the same timeline as other people. There may be feelings of disappointment, sadness, anger, jealousy, impact on self-esteem if they're not reaching the milestones that other people are at the same time. And that can be really distressing. We see this a lot when the individual with Down syndrome is the older sibling and their younger sibling may be passing them up. So that can create some jealousy. So we want to help with goal setting, tangible goals to help them reach their long-term goals. Praising accomplishments, of course, whatever form they may be in. Maybe they're not graduating college, but maybe they are doing really well in Special Olympics, or they tried new foods, or they're getting out and about. These are all worthy of praise. Discuss different options for a fulfilling life. Again, what that can look like for different people, and validate feelings and experiences. Yeah, it is really hard when your sibling gets some big award, or they graduated college and they're getting all this attention, and that hasn't been your experience. That is hard. That's hard for all of us. So we can validate their feelings and experiences and give that attention to their emotions. The idea of individualism, the issues of concern are that different opinions, thoughts, beliefs, from their family members, sometimes that's not valued. We want to have the ability to explore individuality while at home or living with others, the idea of independence versus safety, and conflicts within the home. So some strategies for mental health promotion is allowing the individual with Down syndrome to try to do things their way. I hear from a lot of patients that their family members kind of teach that there is one right way to be an adult, or there's one right way to do things, which is not the case. So if it's not harmful, if it's not dangerous, let them dump all their laundry in one load together if that's the way they want to do laundry, even though that might not be the way that you would like them to do it. That's an individual choice that's not hurting anybody. So assess if it's problematic or just different than the way you would like to do it. Provide necessary information. If you put all of your clothes in one load together, things might shrink, colors might bleed, but if you're okay with that, okay, you can experience that for yourself. And again, those natural consequences. That's how we learn. Friendships and romantic relationships in young adulthood. Relationships change. There's often drama amongst friends, the desire to date and be in romantic relationships. So some strategies are allowing for friendships to change and supporting the individual through that. Teaching skills, social skills related to friendships, boundaries, dating. And again, we have a lot of resources on our resource library about these topics. And again, providing opportunities to meet new people. It's hard to find someone to date if you never meet anyone. So encouraging them to get out and try new things. And I promise I only have a few more slides before we can wrap up. So in older adulthood, we want to maintain habits. Issues of concerns is that there may be a loss of interest in activities or a loss of function and mobility. So we want to try and figure out, why is there a loss of interest? Is it a mobility issue or a health issue, a change in preference, difficulty with seeing or hearing? So, healthcare providers can help sort of maybe rule out some of the things of whether it's a medical issue or if there may be just a loss of interest or a natural decline. We want to continue finding opportunities for engagement. So we don't, what we see sometimes with our older adult is that they don't want to go out, and then it gets harder and harder to get them out of the house. If they say, I don't want to do Special Olympics anymore, that's too hard, or it hurts, to do all these activities. Okay, well then you can sit at home, but then they're sitting at home and they're never going out. Again, continued opportunities for learning. We can always alter the environment. So if it's hard for them to climb stairs or cook a meal, find ways for them to still be engaged. We don't want to just say, okay, you're off the hook. You don't have to, go to your bed anymore, or you don't have to prepare your own meals for yourself. So we can find easy microwave meals that they can do. Or if it's possible, we can move their bedroom down to the first floor or somehow otherwise make it more accessible for them, so that we're still holding them to the abilities that they have, but making it more manageable. So we also want to recognize that certain skills are actually smaller skills within them. And so we don't want to lose the smaller skills for the sake of the big ones. So what I'm talking about is if cooking breakfast, that is actually a skill that's comprised of a lot of smaller skills, like navigating the kitchen, using utensils and appliances, setting the table, pouring liquids, etc. So just because certain aspects of that process may be more difficult, we don't want to lose all the associated skills that accompany it by saying, okay, well, making his breakfast is too hard for him, so I'll just make his breakfast from now on. Well, maybe it was just one aspect of making breakfast that was hard, but we can still encourage him to do the things that he can do as part of that process. We want to hold expectations as their abilities allow, but we can make necessary adjustments. We don't want to totally eliminate activities or opportunities. If their mobility or their functioning no longer allows them to cook full meals for themselves, we can still encourage participation in meals, whether it's just setting the table or sitting with the family or serving themselves or others. There are still things that they can do so that they're not completely missing out on aspects of life. Slowing down, is this an ability or is this a behavior? Again, medical providers may be able to tell you if there's a functional decline due to a medical reason. It's a normal part of aging, right? We all slow down as we get older. It's a lot harder to do things. We're maybe not as interested. And so we want to allow for that to happen to some extent, but still provide opportunities for them to engage with others. And we also see an issue is that the caregiver's abilities to support the individual, if they need more physical support, maybe, a parent can no longer do that as it gets more challenging. So working with medical providers, looking into community agencies who can help with caregiving as necessary, and allowing for some slowing down while not completely eliminating activities. So maybe they don't go to Zumba class anymore, but they can do chair fitness or seated yoga, or maybe they don't go to large social events like the dances, but they can get together with a small group to play bingo or bunko, something like that. Because we all know that in older adulthood, engagement is still really important for mental health. Life changes. We know that there's some unpredictability of changes, which people with Down syndrome tend not to like very much. There are many changes happening at one time, and the individual with Down syndrome may not be open to certain changes. They might really just not like the sounds of certain things. So some strategies for mental health promotion are making changes one at a time when possible. We don't want to do everything all at once. That can feel really overwhelming. We want to prepare for changes in advance. So if they're moving to a new residence, maybe getting them more familiar with it. You don't need to discuss the change right away, like, oh, you're moving out, right? If that's not imminently happening, but taking small steps to make it feel more comfortable and manageable, spending time in the neighborhood where they'll move to, talking about it in a positive way, just sort of being careful about how you approach the topic. We've heard from a lot of families that, families maybe regret the way they said things like, when mom and dad are too old and sick to take care of you, you're going to live over here. And then they're like, what's wrong with mom and dad? And they get, sort of worried about things, and it can cause some stress and confusion and concern. So just sort of thinking about ways to address this in a way that are more manageable for them to sort of intake that information. You can provide encouragement about the things that will remain the same. Yes, maybe there are some changes that are happening. You're going to go live with your sister. However, we're still always going to have Christmas at Aunt Jean's house, or you're still going to get to go to your day program or visit with your friends. That can help reduce the feelings of being overwhelmed. And put supports in place before major changes happen. We know that a lot of families logistically, financially, emotionally say that, okay, well, I, as their parent, am going to care for my child with Down syndrome until I am no longer able to. But if it's the case that the caregiver is sick or dies, right, what does that look like for the individual with Down syndrome? They're going to have new caregivers. They're going to have to move to a new house. There's going to be major changes. They're going to be grieving. So it's a lot to handle at once. So just keeping in mind, how can we minimize overwhelming situations? And so the support's in place again, also, like if we're worried about moving out, we can make plans for activities, phone calls, home visits, making it more manageable a little bit at a time. So the treatment approaches that we sort of support are things like counseling. If there are issues that are coming up, it can be really good to have a counselor to talk to. A therapist's job is to listen non-judgmentally and hear everything, which we know even the best meaning families, it can be really hard to have the time and the energy and know what to say to a loved one. So that's where therapists can come in and sort of just, they can get it out, they can express themselves, and we can work through some problems. Sometimes medications are indicated. There's no right or wrong way. Some families say, I want to do counseling first and see if that helps resolve the issue before considering medication. Other times the families say, no, let's get that medication going so that they can actually engage in counseling, because without the medication, I can't get them out of the house or they're not going to talk. So it can go either way. Sometimes behavioral therapy can be helpful if there's a therapist who comes out to the house and can help in real time in the environment where it's happening. That can be very helpful. Occupational therapy is also something we're big promoters of, because there are many sensory needs that come across as behavioral issues or mental health issues. But if you can resolve sort of some of the sensory or the occupational needs, then it can resolve the situation. And so there, again, no right or wrong way to consider different treatments. That there's timelines. It's sort of whatever you can sort of try and test out and see what works. I'll send this out. It's got all of our resources, links to our resources, the mental wellness book by Dr. Chicoine and Dr. McGuire, of course, free of charge on our available on our website. My contact information, I will give that out as well. And all of our good social media accounts and supporting our mission. But that is all that I have. So Julie, I know I talked super long.